Thanks again, Dr. Paula Ferrada, for talking to the Op Report. Tell us about C. diff, or Clostridium Difficile management. When should somebody call a surgeon for C. diff?
Yeah, I think this is an important topic because the infection of C. diff, even though it's getting better in the United States, is not perfect. And when people get too sick, sometimes surgeons get called a little bit too late in the course of the disease. And I think early surgical intervention definitely will save lives. So when you have a patient that had a Clostridium difficile infection and you see that the patient is deteriorating and has one or two or more SIRS criteria, if the Y count is going up or is too low, if your patient is febrile, is tachycardic, if it becomes hypotensive, that is the time to get a surgeon involved. That doesn't mean that the surgeon is going to do surgery immediately, but there has been several papers that shown that early surgical involvement actually save lives. Mm-hmm. Now, once the surgeon is involved in the care of these patients, is important that the decision of taking this patient to the OR is also done timely.
Mm-hmm. What are the indications?
So we just wrote a guideline on this. The indications are, obviously, if you have a patient that is peritoneal, this patient needs to go to the operating room. Mm-hmm. But if the patient is deteriorating, the patient probably will do better if you take him to the operating room before this patient develops multi-organ system failure, renal failure, respiratory failure requiring a ventilator, and or circulatory failure requiring vasopressors. Sometimes we get called when all of these things are already in place, and most of the time these patients have multifactorial reasons why they have C. diff and now they're sick. In that case, you have, in the literature is described, you have about 3 days to make up your mind whether if you go to the operating room or not, because if you do it too late, then the mortality increases up to above 80%. So when you're, when the cat is already out of the bag, physiologically the patient cannot take another hit. Additionally to the multi-organ system failure to have surgical treatment, because the operation that you're going to do, takes time, and it also takes a physiological toll on the patient.
What is that operation? What do you do for people with C. diff?
So the gold standard recommendation right now is total colectomy. In fact, the patients that did worse in our review are patients that they went to the operating room, they opened them up, they saw a boggy colon, did not resect anything, they closed them back up, and then subsequently needed a total colectomy. Those patients are the ones who do the worst. Why? The colon is an infection of the mucosa. So you're not going to see something terrible outside unless the colon is dying. And even if the colon is dying, the bowel dies from the inside out.
Right.
Correct?
So it looks different from a case of like your typical ischemic colon or some other source of a dead colon.
Absolutely. So the source of sepsis is the toxin, which is systemic, and also the infection is in the mucosa. So even if you're seeing necrosis in the colon, it's too late. Even if you have a piece of necrotic colon and the rest is not necrotic, the whole colon needs to come out. Mm-hmm. And so there's a Pittsburgh paper that shows that by doing an ileostomy, washout with golightly, and then high dose vancomycin NMS into the colon, they had a better prognosis and decreased mortality. But that has not been able to be reproduced yet. We have another multicenter trial that we're doing now, seeing what is the experience of the rest of the country with this protocol, and how can we, because what we have seen, at least here locally, is when people are too sick, like too far off, and you do this procedure, there's a chance of failure, and that chance of failure in most cases for these patients means a mortality, means
Sure.
death. So because we don't know exactly, it would be great if we could have a protocolized care in which we say, with this criteria you take to the OR, with this criteria in the OR you can do ileostomy and washout, with this criteria you remove the colon. And then if those patients, the advantages of doing an ileostomy and washout is that it's a shorter procedure, you have less blood loss, and at the end, you could sometime in the future when they are better from the multi-organ system failure, you could consider in reanastomose them. Those patients, there's still a question in when is the best timing to do that as well, because we also have seen locally that there's a high recurrence of C. diff when you anastomose them back. So there's still a lot of questions to be answered regarding that procedure. I think it has a great potential for the future, but we need to make sure that everybody's on the same page when treating these sick patients, because I think that if together we come up with something protocolized, it will benefit patient care ultimately.
You said there's a multi-center trial investigating the treatment options?
Correct. So we first we started a multi-center trial of a prospective randomized trial doing total colectomy versus ileostomy, loop ileostomy and washout. We had to close it because we didn't have enough enrollment. I am right now the national PI for a multi-centric trial in looking at this retrospectively. The people that already had the total colectomies or the ileostomies, what were the outcomes? So we can at least start defining it. And we have several centers right now, and the results are different depending on the center. So if anybody that is listening to this video wants to join, please do so. We still need more.
In other words, you are recruiting centers to participate in the trial.
We're still recruiting, and it's an easy study to participate, because all you need is the IRB for retrospective review, and then pulling the data into the database.
Okay, great. Last words on C. diff.
Call a surgeon early. Aggressive infectious disease management at the beginning. When you have a patient with severe C. diff and they're already with SIRS criteria, flagella alone is not going to do. You have to start giving vancomycin per mouth and per rectum, and vancomycin at high doses, and educating everybody. This is a team effort. It's not only the surgeons alone and the emergency physicians alone and the medical team alone. To get these patients to survive and to a better outcome, we need to all work together so we can help the patients better.
Thanks again, Dr. Ferrada.
Thank you.
Bye-bye. Thanks for checking out the Op Report. Help us keep conversations alive on topics in general surgery. Check out more episodes of the Op Report and other OnSurge content here at YouTube. Find us at Facebook. Follow us on Twitter. And find our homepage at onsurge.com. Join the conversation and tell us what topics you'd like to hear about and what people you'd like to hear from.